Can we do closed reduction of fractures in adults? In the first slide, you have two pictures with neglected displaced fractures. And on the other side, this is after healing. Can you imagine that you can reach this point on your right-hand side without any surgical incision? We are going to answer this question in this lecture. I have two questions about long bone fracture in adults. Can you reduce the fractures without surgical exposure? Totally close the fracture without any incision? Can you imagine that? Can you reduce the fracture in adults without anesthesia? That means if you have a displaced fracture after the operation, can you imagine that you can reduce the fracture without taking the patient to the operating theater again? Or it's not feasible, it's not possible. And this is an example of unacceptable open reduction. You see the depression of the medial condyle. The joint line is this. This is severe displacement with double plating. If you want to correct this problem, you have to do revision. You have to take the patient to the operating theater again. So if you have a problem, operative problem, and you found out after the operation with post-operative X-ray that you have a displacement, you have to take the patient and remove the plates, and you do another open reduction and internal fixation. Again, if you look, this is unacceptable open reduction. If you look to the lateral and you have two plates, you have a gap on the lateral about 12 millimeters in the lateral view. And this is not acceptable, of course. If you want to correct it, you have to take the patient to the operating theater again, remove everything, and do another reduction and fixation. What I mean by closed reduction of fracture in adults: manipulation of the bone fragments without surgical exposure, no surgical exposure, nothing. It's not indirect reduction. It's one way of indirect reduction, but it is not indirect reduction. How to do closed reduction with a circular fixator? An example of the closed reduction techniques. This is an example of the closed reduction techniques. In this comminuted supracondylar fracture, we put two olive wires opposite each other, and we use the tension if needed. Sometimes we don't need tension. Or in this tibial plateau fracture, again, you have two olive wires, and you can put cannulated screw or lag screw. The arched wire technique. In this arched wire technique, we can put a K-wire through the fragment that displays the fragment. Like this picture, if you remember. In this picture, we removed the plates and we put a wire posteriorly in the posterior segment and another wire in the anterior segment. We bent the anterior wire posteriorly and the posterior wire anteriorly, and then we did tension. So we compressed both fragments without open reduction. Again, if you have a large fragment, you can use many olive wires, 2 or 3 olive wires. If you have a posterior fragment, you can use the olive wire from posterolateral, posteromedial to correct it. With circular fixator, we can use the closed reduction techniques. What does it mean? You can correct the deformity, or you can correct, or you can achieve anatomic reduction during the operation with the closed reduction techniques or post-operative. That means the patient will be out of the operating theater with a lousy reduction. It's not good reduction, but you can reduce the fracture closed in a closed manner without anesthesia after the operation, post-operatively. We can take to correct the displaced fragments maybe 1 month, 2 months. The third option is operative and post-operative. That means you can correct part of the fracture during the operation, and then gradually you can correct the rest of the fracture. So we have 3 options in the closed reduction techniques by circular fixator. You can correct, you can reduce the fracture during the operation or post-operatively after the operation without anesthesia in the outpatient clinic. Or you can do operative reduction, perhaps of the intra-articular parts, then you correct the metaphyseal part post-operatively. So we have three options: operative reduction, post-operative reduction, or operative followed by post-operative reduction, and I will give you an example. This is an exercise showing you how to do operative reduction. This is comminuted distal femoral intra-articular, extra-articular fractures. We are going to correct it by closed reduction techniques. Imagine that you are helping me in the operating theater, because many of my colleagues and fellows complain that when we discuss the reduction, we don't show them the real thing, but I'm trying to simulate the real thing. We imagine the patient in the operating theater, and we have the image intensifier and how we deal with this comminuted fracture of the distal femur. This is a magnified picture of this fracture. The patient is 76 years old with osteoporosis, as you see here. 76 years old with osteoporosis, and he has heart problem, I think cardiac problem. He had 3 stents before, and the patient is diabetic. We usually do 3D CT. As you see, this is the CT showing the intra-articular fracture. Also, we do, this is sagittal plane CT, coronal plane CT, like the AP, and transverse CT to judge the fracture or to evaluate the fracture. And imagine now we are in the operating theater. We start the operation by aspiration of the effusion. We aspirate the effusion of the knee. Then we do minimal or very slight traction with the assistant just pulling distally the leg. We don't do significant traction. We believe that sometimes severe distraction can cause displacement of the fragments. Now we manipulate under the image intensifier. You see here to evaluate the metaphyseal part. You see how to move the fragments for the alignment. Now we put the circular frame for the proximal part. We fix the proximal part. There's no fracture in the proximal part, and we want to have a base, fixed base. So when we move, we have a fixed base. We fix the proximal fragment of the femur. Now we use an arch and half ring, using half pins with an angle, good angle in between to have rigidity of the frame. Now we have fixation of the proximal fragment. We start manipulation of the distal fragment. How we manipulate the distal fragment? With the assistant keeping minimal traction, and we did aspiration of the joint, we used the hand between my hands, and I manipulate the fragments. This is exactly the picture in the operating theater. This is a slight traction. My assistant is very weak, so it's not strong traction or something. Now, I fix the proximal part with one hand, because I'm keeping the proximal part or the proximal part of the frame. Then my left hand, I use my thumb and the hand to push the fragments or the distal femur with my hand. So this is manual reduction of fractures. And now, if you see, my thumb is over there in this X-ray, in this under image intensifier. And if you look, closer look, we have anatomic reduction of the intra-articular. Anatomic, forget now about the distal or the metaphyseal part. Now, because we have anatomic reduction of the distal part, we put the first key wire to fix the fragments. The first key wire As you see, the first K wire is parallel to the joint, and it will fix the fragments together. And this is the picture. We usually put another 2 wires with olives opposite each other, because this is not the stable part of the fracture or the interarticular part. And we put, as you see, we put the ring in the distal part of the fractures. We don't fix or we don't mount the wires to the ring in the first place. Till we see this picture, we look to the anatomic reduction of the distal part, and we use 2 olive wires opposite each other. So we lock the fracture. So we have 2 olive wires opposite each other. We don't tension the wires at this stage, because in maybe 50% of cases, we don't need to do traction, or we don't need to tension the wires. In such a case, we just put an olive wire and we pulled it by hand, another olive wire in the opposite way, and we pulled the wires just by hands. This is manual reduction. We don't use tension. Then, after we get this picture, we start mounting the wires to the frame. Now we fix the wires to the frame, to this ring, as you see here. And during manipulation, you see the metaphyseal part is moving. We don't worry about this at this stage. Now look we fix the wires to olive wires and the third wire to the ring, the distal ring, and look to the reduction. It's anatomical reduction of the distal part. Now we finished the distal part, we have anatomical reduction. Now we manipulate between the distal part and the proximal part. You see this manipulation between the proximal part and the distal part to move and to see the alignment. You see the alignment? Now we have good reduction. We thought it's good reduction. We start fixation of the distal ring to the proximal part using rods, as you see here. The rods, we put 2 rods first. The rods medial and lateral. Just medial and lateral. We don't put more. Why? Because still, maybe you want to rotate the distal fragment, because we have malalignment in the sagittal plane. In the AP, it's okay. It's very good reduction. Anatomical reduction of the intra-articular part and the acceptable reduction of the metaphyseal part. Now we have to look for the sagittal plane, because in the sagittal plane, perhaps you are going to have displacement and you want to correct it by moving the distal ring. So we keep only medial and lateral rods so we can move the rings this way. Look to the X-ray. To the lateral, this is sagittal plane, total displacement. So in spite of the AP or the coronal plane, you have very good alignment, but in the lateral view, it's total displacement. You have a gap, you have flexion of the distal fragment. Remember, when we put the frame, usually the frame is vertical to the distal part of the bone. We put in mind that we have a flexed fragment. If you try to do compression, you have more displacement. Look here, we have more flexion. Flexion is something like 30 or more degrees if you do compression. So we are not going to do this. We are going to do distraction and displacement of the ring. When we displace the ring, we increase the declination of the ring. Now we have good alignment, but we have a gap. It's about 2 centimeters gap. Distraction, and we increase the inclination of the distal fragment. Now we have a gap about 2 centimeters. What are we going to do? Again, we have a look on the AP to be sure that we have anatomical reduction of the distal view. Just to have a look. Again, coming back to the lateral view, we used the arched wire technique. We use the K wire in the posterior segment. You check here. We have a wire on the posterior segment over a second level, and we use the tension wire. We bent the wire anteriorly, and then we did this. We did tension of the wire. When we do tension of the wire, we raised the fragment till we have almost anatomical reduction. We still have anteriorly a small butterfly, but we leave the butterfly. It's a small butterfly. The small one anteriorly and small one anteriorly. But look to the cortex, it's almost anatomic reduction of the two cortices, anterior and posterior. Now we corrected in the sagittal plane, we get back on the AP plane, on the frontal plane, and we used to put olive wires. Olive wires because there was some sort of displacement in the AP plane, and we moved the olive wires so to displace these fragments, and we correct. This is the lateral view, because now we have to do compression after reduction. We have good reduction, we do compression by tightening the nuts, and we do compression of the metaphyseal part of the fracture, and we don't have a gap. Look to the compression, look to the anterior and posterior cortices. We finished the operation. The patient comes to the office after 1 week. We do long-standing film. We treat fractures as deformities. You have to know that we've learned most of our knowledge from reduction, from deformity correction or deformity analysis from fractures. We do long-standing film for this patient. For the long-standing film, it's important to know two things: the alignment. We draw the mechanical axis. And in this patient, after the operation, in the comminuted fracture, we had valgus deformity of the lower femur. With the metaphyseal part, we have valgus deformity. What we did, we put this traction on the lateral side and the hinges over the cora, and we corrected the mechanical axis. Limb length discrepancy, especially in these comminuted fractures, we have to be sure that the length of the femur here is exactly the length of the femur. So long-standing film after 1 week in the operating theater is very important. If you have malalignment, you can correct it in the outpatient clinic without anesthesia by gradual correction. And limb lengthening, you can do shortening or lengthening 1 millimeter per day. As you see here, we have a valgus deformity. If you have a magnified picture, this is clear. We didn't realize that during the operation. We didn't. There is no problem at all. As you see, gradually, this is the patient, 76 years old patient, diabetic with osteoporosis, and this is closed treatment of fractures. We corrected the valgus deformity, and this is the long-standing view of the AP and lateral, to be sure. And this is after union, complete union of fracture. This was operative treatment. I will give you another example of closed operative treatment of fractures in adults. In this case, we have a metaphyseal gap. We have a tibial plateau fracture, comminuted fracture, both condyles, as you see in this picture. Again, this is a coronal CT, sagittal CT, transverse CT, and 3D CT to show you the real picture of the fracture. And this is the soft tissue. Some people claim that you have to wait till healing of the soft tissue, but we think that if you fix the fragment, if you reduce the fragments, you can have rapid recovery of the soft tissues. This is not an open fracture, but we have a massive soft tissue injury. Look to the picture of the skin of this tibial plateau fracture. Again, this is a diabetic and fat patient, diabetic fat patient. We started the operation again by doing aspiration of the effusion, and then manual distraction, just manual distraction and manual manipulation by hands. This is close treatment of fractures using manual reduction. You see, with manual reduction, we obtained almost good reduction. Now we want to have anatomic reduction of the articular part. So we do manipulation by hands during distraction. Look at the X-ray picture or the image picture. Those are my hands on both sides, manipulating the fracture. And this is my thumb, as you see the picture. We try to correct the anatomical, to get anatomical intra-articular part. And this is a metaphyseal gap. We have a metaphyseal gap. How are we going to manage this gap? First, we do the first wire application, as you see here, to fix the fragments after reduction. Then we put an olive wire from lateral to medial, another olive wire from medial to lateral, and we pull them opposite each other. We don't use tension. We don't need tension. In many cases, we don't need it, especially in fresh fractures, whatever the severity of the fracture. Now we closed the gap. There was a 2 millimeter gap. We closed the gap by pulling the wires opposite each other. Look to the lateral view. Don't forget that we have to look to the lateral view. In the lateral view, you see we have the olive wires. There is anatomic reduction of the intra-articular part, but we have an evident, clear gap. The metaphyseal gap is something like 3 centimeters. It's not a small gap. If you want to put a graft, perhaps you need 3 packages of synthetic graft in this patient. And he has a fat belly, and so it's very difficult to get a cancellous bone graft. It's not enough. So again, we have a full picture of the fracture. We start to apply the frame. We have 2 olive wires, and we apply the frame to the proximal segment. Again, 2 olive wires opposite each other to increase the stability, and we added 2 olive wires more. We want to have stability of the proximal segments. So we add more olive wires opposite each other. Then we start to put the frame in the distal and the proximal part. Now the frame, we have the frame and rods. See the frame. And we started manipulation of the distal part by hand. First, we put 2 K wires in the distal part, in the coronal plane, so we can move the distal fragment medially or laterally by hand, just manipulations. We want to have acceptable metaphyseal reduction. And now we moved the fragment using olive wire because there was medial displacement of the distal part. We put an olive wire and we tension the wire from the lateral side till we get almost alignment, good alignment of the metaphyseal. Again, look to the sagittal plane. The sagittal plane, again, we have movement of this part. So we have to move or incline, increase the inclination in the sagittal part of the ring to improve the alignment. Look here, we improved the alignment of the proximal ring by changing the inclination of the proximal ring. But still, we have a huge or a large metaphyseal gap. Again, acceptable reduction with a metaphyseal gap. Look to the AP and lateral. This is acceptable reduction, but we have a metaphyseal gap. What are you going to do with the metaphyseal gap? To put 3 or more synthetic graft packages, or synthetic graft and cancellous bone graft? No, we don't. In such a case, we decided to close the metaphyseal gap. During the operation, we closed the gap. We considered the metaphyseal fracture as a corticotomy, closed corticotomy. We considered the gap as a closed corticotomy, or a fracture as a closed corticotomy. And we closed the gap acutely. With closure of the gap, we have some or mild displacement in the sagittal plane. We accepted it for the time being. We're not going to accept it on the long run. So we had compression for about 3 centimeters, compression. And then we have a latency period for 2 weeks. We waited for 2 weeks before we started distraction for 1 millimeter per day. And look now, after distraction, gradual distraction, 1 millimeter per day, we regained the reduction. We have a good reduction in the metaphyseal part, and look to new bone formation. It's distraction orthogenesis. So we overcome the metaphyseal gap by distraction osteogenesis. We have this 3 centimeters. We have very good new bone formation. We consider the osteotomy. We consider the fracture or the metaphyseal fracture as a corticotomy or a closed osteotomy. So we can overcome the gaps by distraction osteogenesis. The other example, how to use the closed production techniques to have operative and post-operative production. And this is an example. We have floating knee, you have a comminuted fracture of the tibial plateau fracture, and you have a comminuted distal femoral fracture in the same patient. The patient presented to us after 3 weeks of the injury. And we did operative anatomic reduction using olive wires, as you see here, of the intra-articular part of the tibial plateau and the distal femur. So we have anatomic reduction by olive wires of the distal femur. But look to the metaphyseal part. Total displacement. We have a total displacement. This is a post-operative picture in my patient, in the outpatient. So the patient came out of the operating theater with anatomic reduction of the intra-articular fracture and total displacement of the metaphyseal fracture. You see the lateral, this is total displacement, no cortical contact. What are we going to do? Now we consider the fracture as a deformity. How are we going to do this? Look to the total displacement. We started to do coronal plane translation of the distal ring, 1 millimeter per day. We teach the patient, we change the construct like this, and we teach the patient to move 1 millimeter per day, and within a couple of weeks, we had correction of the anatomic reduction of the AP. You see here, from left to right, from your left hand to the right your hand side. This is immediately after, then closed reduction, we have anatomic reduction, then we have compression, but by side-to-side compression, because I have a short oblique. If you do axial compression, you're going to have short. So if you have short oblique, we are going to do a lateral side-to-side compression by increasing the lateral distraction. And look to the lateral view. We have the displaced distal fragment posterior. So then we changed the construct and we moved the distal fragment 1 millimeter per day. 1 millimeter per day, the patient moved 1 millimeter per day. Then we move the fragment till we have overcorrection. Why we do overcorrection? Because the patient is in the displaced position now for more than 3 weeks, and there's a fear of soft tissue interposition. If you do distraction, overcorrection, there's no problem with the soft tissue interposition. Because many people think if you have a neglected fracture, you have to do an open reduction because of the soft tissue interposition. We don't think that this is mandatory for the closed reduction techniques. For the closed reduction techniques, if you use gradual distraction and the gradual overcorrection, you can get rid of the problem of soft tissue interposition. And this is the magnified picture. How we did anterior translation of the distal fragment from posterior to anterior, and then we have overcorrection or over displacement of the distal fragment. Then we treat the fracture as a deformity. How come? We decide the core or the apex of the deformity. We draw the mechanical axis of the proximal segment, and then the mechanical axis of the distal segment. The core is about 2 centimeters above the fracture site. Then we use distraction. We put a hinge on the convex and the concave side, and we put 2 hinges over the core, and we correct the deformity 1 millimeter per day. Look to the lateral view. With this correction, gradual correction, we have anatomical reduction in the lateral view. We gained anatomical reduction 1.5 months after the operation, gradually 1 millimeter per day. And this is real merit what we do. You see here anatomic reduction. Take care that the patient has varus knee of the lateral of the tibia on both sides. Now we do long film to be sure that the length is the same, or perhaps we have a mechanical axis deviation. Again, with the follow-up, we have a long film, and this is postoperative X-ray with the follow-up showing you the united fractures and the alignment. Again, another example of the post-operative reduction. In this patient, we didn't do any reduction during the operation. The patient has massive infection coming after 5 weeks with previous neurovascular injury and severe infection. The wound is boring pus. And this overlap, it's about more than 12 centimeters around. People would think this patient has to have open reduction because there is soft tissue. Of course, there is soft tissue interposition. I'll show you how we manage it. Now we do gradual. The patient comes out from the operating theater with total displacement. We did nothing. Afterwards, we do distraction, 2 millimeters per day. Why 2 millimeters? Because this is a traumatic case. We do 2 millimeters per day, gradual distraction, as you see, and we started to have the normal length. Then, this is the AP and lateral position. You see the displacement. We started to have side-to-side correction in the coronal plane till we had correction, and after we had correction in the coronal plane for this oblique fracture, we have displacement in the lateral plane. The distal fragment is posterior. We moved it anteriorly, 1 millimeter per day. You see here before, and this is after gradual correction, 1 millimeter per day. This is the picture after 2 months of the operation. How we can get rid of the soft tissue interposition by gradual distraction and overcorrection. You see the picture with almost anatomic reduction. You see good union. You see the callus formation. It looks like distraction osteogenesis. And this is postoperative, and this is the follow-up. Look to the alignment and the bone formation. This is closed post-operative treatment of fractures. Again, polytrauma patients, you can use operative and post-operative correction, like this picture. We decided to have operative correction, and we have fractured femur and tibia and the gloved injury of the foot in this patient and amputated toes. This is the soft tissue of this patient, so for the picture. And then we use the closed reduction technique for the femur and the tibia. As you see, we have good alignment. We thought it's good alignment. We left the small butterflies, and with the follow-up, we did an X-ray. It was okay, long film, and then after 2 months, we noticed that we started to have a varus deformity. See, this is the soft tissue after 2 months, marked improvement. We use the VAC for the foot also. And we have full recovery of the soft tissue. And during follow-up, as you see, we had varus deformity. After 2 months, we noticed that. Why we didn't notice it? Because the patient, the X-rays, the long films, were done in rotations, and that's why we missed the varus deformity. So we noticed the varus deformity or the displacement 2 months after the operation. However, we decided to correct it, no problem at all. We did distraction from the middle side, from the medial side, and we put 2 hinges. And you see the distractor on the medial side, and we put 2 hinges, and 1 millimeter per day. We gradually, after 2 months of the operation, we corrected the varus deformity. You see here the correction with complete union, and this is the foot and the tibia. And you see the union. How good the callus is, because this is closed treatment, purely closed treatment of fractures. We don't do any incision. And this is with the follow-up. See the alignment and the bone formation. And the knee motion afterwards. Because the people claim If you put the frame, we're going to, there will be a problem of the bone formation. This is not true. This is not true. Most of these rumors are coming from people not doing these maneuvers. Again, we are going to ask you the two questions again. Can you reduce the fractures in adults without surgical exposure? I think the answer now, yes, we can do this. Can you reduce the fracture in adults without anesthesia? Yes. 2 months, 3 months after the operation, you can reduce the fracture in the outpatient clinic without any anesthesia, without painkillers or something 1 millimeter per day. In conclusion, the merit of the use of the circular fixator as a definitive treatment is close treatment to fractures, whether operative, post-operative during follow-up, or both. Can you imagine the merit? You don't have to panic. If you discovered after 2 months that you have mild venous deformity, you can correct it. You can correct the deformity, you can correct the fracture operatively and without anesthesia, post-operatively and after the operation. Thank you very much.